Regional anesthesia. RA. Expanded lecture note. Imagine undergoing surgery without the risks and discomforts of general anesthesia. Welcome to regional anesthesia, a game-changing approach that numbs specific regions of the body, providing effective pain relief and revolutionizing the surgical experience. Join me as we explore the world of regional anesthesia, its benefits, techniques, and applications, and discover how it's transforming the field of medicine. Objectives. By the end of this lecture, the student should be able to 1. Define regional anesthesia and understand its principles. 2. Trace the history and evolution of RA. 3. Classify types of regional anesthesia. 4. Describe the mechanism of action of local anesthetics. 5. Understand pharmacology of commonly used local anesthetics. 6. Discuss techniques of regional blocks, neuraxial and peripheral. 7. Outline indications, contraindications, and complications. 8. Apply RA principles in various surgical and critical care settings. 9. Recognize the role of RA in multimodal anesthesia and pain management. Definition of regional anesthesia. Regional anesthesia is a technique in which local anesthetic drugs are administered to block nerve conduction in specific regions of the body, resulting in loss of sensation and sometimes motor function in that region, while the patient remains conscious or sedated. 1. Regional anesthesia is a technique, a medical procedure that targets specific areas of the body. 2. Local anesthetic drugs are administered, medications that numb the area, preventing pain signals. 3. Block nerve conduction. The anesthetic interrupts signals, preventing pain transmission. 4. In specific regions of the body, targets specific areas, such as arms, legs, or abdomen. 5. Resulting in loss of sensation. Patients experience numbness or reduced feeling in the targeted area. 6. And sometimes motor function. Depending on the type of block, patients may experience temporary weakness or paralysis. 7. While the patient remains conscious or sedated, patients are awake or lightly sedated, allowing for faster recovery and reduced risks. History of regional anesthesia. 1. 1884. Carl Koller introduced cocaine for topical anesthesia in ophthalmology, marked the beginning of local anesthesia, revolutionizing pain management in eye surgery. 2. 1885. Leonard Korn formed the first spinal anesthesia, accidental although unintended. This paved the way for future developments in regional anesthesia. 3. 1898. August Beer successfully used spinal anesthesia with cocaine, demonstrated the potential of regional anesthesia for surgical procedures. 4. 1901. Heinrich Braun added adrenaline to local anesthetics, improved the safety and efficacy of local anesthetics by prolonging their effects and reducing toxicity. 5. 1905. Procaine was synthesized, the first safe synthetical anesthetic, reducing the risks associated with cocaine. 6. Modern era. Lidocaine, bupivacaine, ropivacaine, safer and more effective local anesthetics have been developed, expanding the options for regional anesthesia. 7. Safer techs with ultrasound and nerve stimulators. Advanced technologies have improved the precision and safety of regional anesthesia, reducing complications and improving outcomes. Goals of regional anesthesia. 1. Provide analgesia and/or anesthesia for surgery. Regional anesthesia effectively manages pain and discomfort during surgical procedures. 2. Minimize systemic drug effects. By targeting specific areas, regional anesthesia reduces the need for systemic medications, minimizing side effects and risks. 3. Avoid airway manipulation. Useful in difficult airway, regional anesthesia eliminates the need for airway management, making it a valuable option for patients with difficult airways. 4. Provide muscle relaxation in specific regions. Regional anesthesia can provide targeted muscle relaxation, facilitating surgical procedures and reducing the need for systemic muscle relaxants. 5. Reduce perioperative morbidity and mortality. By minimizing systemic effects and avoiding airway manipulation, regional anesthesia can contribute to improved patient outcomes. 6. Postoperative pain relief, e.g., epidural analgesia. Regional anesthesia can provide effective pain management after surgery, reducing the need for opioids and improving patient comfort. Mechanism of action of local anesthetics. 1. Local anesthetics block sodium channels, preventing the influx of sodium ions into the neuronal cell membrane. 2. In the neuronal cell membrane, the site of action for local anesthetics, where they interact with sodium channels. 3. Preventing depolarization, blocking the electrical impulse that normally triggers nerve conduction. 4. And conduction of nerve impulses, stopping the transmission of pain signals to the brain. 5. Smaller, myelinated fibers pain, autonomic or blocked before larger, motor fibers. Local anesthetics affect smaller fibers first, leading to a specific sequence of sensory and motor blockade. 6. Order of block. Autonomic, pain, temperature, touch, pressure, motor. This sequence explains why patients may experience a progression of sensory changes, from loss of autonomic function to motor weakness, as the block takes effect. Classification of regional anesthesia. 1. Central neuraxial anesthesia. 1. Spinal anesthesia, subarachnoid block. SAB, injecting local anesthetic into the subarachnoid space, providing rapid onset of anesthesia for lower body surgeries. 2. Epidural anesthesia, administering local anesthetic into the epidural space, allowing for continuous pain relief and anesthesia through a catheter. 3. Caudal anesthesia, a type of epidural anesthesia where the local anesthetic is injected into the caudal space, often used in pediatric patients. 2. Peripheral nerve blocks. 1. Upper limb blocks. Brachial plexus interscalene, supraclavicular, infraclavicular, axillary blocks at different levels of the brachial plexus provide anesthesia for various upper limb surgeries. 2. Lower limb blocks. Femoral, sciatic, popliteal, ankle block. These blocks provide targeted anesthesia for lower limb surgeries, reducing opioid requirements. 3. Truncal blocks. Intercostal, paravertebral, TAP, transversus abdominis plane, disc sheath block. These blocks provide anesthesia for abdominal and thoracic surgeries, reducing postoperative pain. 3. Field blocks and infiltration. 1. Local infiltration anesthesia, injecting local anesthetic directly into the surgical site to provide pain relief. 2. Field blocks, e.g., hernia repair, injecting local anesthetic around the surgical site to block pain signals. 4. Topical anesthesia. 1. Surface application, e.g., eye drops, lidocaine spray, applying local anesthetic directly to the surface of the skin or mucous membranes to provide topical pain relief. Pharmacology of local anesthetics. Chemical classification. 1. Esters. Procaine, chloroprocaine, tetracaine, metabolized by plasma cholinesterase, leading to rapid breakdown. More allergic reactions due to para-aminobenzoic acid (PABA) metabolites. 2. Amides. Lidocaine, bupivacaine, ropivacaine, prilocaine, metabolized in the liver, resulting in slower breakdown and longer duration of action. More stable and less likely to cause allergic reactions. Important agents. 1. Lidocaine. Rapid onset and intermediate duration of action, 1–2 hours. Effective for infiltration, epidural, and peripheral nerve blocks. 2. Bupivacaine. Slow onset and long duration of action, 3–8 hours. High potency but also cardiotoxic in overdose, requiring careful dosing. 3. Ropivacaine. Similar to bupivacaine but with less cardiotoxicity. Preferred in obstetrics and for patients at risk of cardiac complications. 4. Prilocaine. Moderate duration of action. Risk of methemoglobinemia, a condition where hemoglobin is oxidized, reducing oxygen delivery to tissues. Factors affecting regional anesthesia block. 1. Drug properties. Potency determines the effectiveness of the local anesthetic. Lipid solubility affects the rate of onset and potency of the block. Protein binding influences the duration of action and toxicity. 2. Dose, volume, concentration. Dose. The amount of local anesthetic administered affects the block's intensity and duration. Volume. The amount of solution injected influences the spread of the block. Concentration. The strength of the local anesthetic solution impacts the block's onset and duration. 3. Site of injection. Vascularity. Areas with high blood flow may absorb the local anesthetic faster, reducing its effectiveness. Tissue type. Different tissues e.g., fat, muscle can affect the spread duration of the block. 4. Addition of adjuvants. Epinephrine, adrenaline prolongs the block by causing vasoconstriction, reducing systemic absorption and increasing the duration of action. Techniques of regional anesthesia. 1. Spinal anesthesia. 1. Injection of local anesthetic into subarachnoid space L3-L4. L4-L5 provides rapid onset of anesthesia for lower body surgeries. 2. Indications. Lower abdominal, pelvic, lower limb surgery, suitable for procedures below the umbilicus. 3. Advantages. Rapid onset, dense block, small dose, effective anesthesia with minimal drug usage. 4. Complications. Hypotension and bradycardia due to sympathetic blockade. Post-dural puncture headache PDPH from dural puncture. High spinal can lead to respiratory compromise. Infection and hematoma are rare but serious complications. 2. Epidural anesthesia. 1. Injection into epidural space lumbar, thoracic, caudal allows for segmental anesthesia and analgesia. 2. Catheter allows continuous infusion, enables prolonged pain relief and anesthesia. 3. Indications. Labor analgesia, thoracic, abdominal surgery, effective for pain management in childbirth and major surgeries. 4. Advantages. Titratable anesthesia allows for adjustable dosing. Prolonged pain relief with continuous infusion. Less risk of PDH compared to spinal anesthesia. 5. Complications. Dural puncture can lead to PDPH. Systemic toxicity from accidental intravascular injection. Infection and hematoma are potential risks. 3. Peripheral nerve blocks. 1. Single injection or continuous catheter provides targeted anesthesia for specific nerves or regions. 2. Techniques. Blind technique relies on anatomical landmarks. Nerve stimulator uses electrical impulse to locate nerves. Ultrasound guided is the gold standard for precision and safety. 3. Complications. Nerve injury from needle trauma or local anesthetic toxicity. Hematoma from vascular puncture. Last, local anesthetic systemic toxicity from accidental intravascular injection. 4. Field infiltration. 1. Direct infiltration of wound margins with local anesthetic provides localized pain relief for minor procedures. 2. Indications. Minor surgeries, skin suturing, suitable for small, superficial procedures. 3. Advantages. Simple and effective technique. Minimal risk of complications when used appropriately. Local anesthetic systemic toxicity last. Cause. 1. High plasma concentration. Occurs when local anesthetic is absorbed too quickly or injected directly into a blood vessel. 2. Intravascular injection or overdose, accidental injection into a vein or artery, or excessive dosing, can lead to toxicity. Symptoms. 1. Early symptoms. Circumoral numbness, numbness around the mouth. Tinnitus, ringing in the ears. Metallic taste. Agitation or anxiety. 2. Late symptoms. Seizures due to central nervous system toxicity. Arrhythmias and cardiovascular collapse from cardiac toxicity. Management. 1. Stop injection immediately. Halting the administration of local anesthetic can prevent further toxicity. 2. Airway, oxygen, seizure control. Benzodiazepines ensure a patent airway, provide oxygen, and control seizures with benzodiazepines. 3. IV lipid emulsion therapy, intralipid 20%, lipid rescue. Lipid emulsion therapy helps sequester local anesthetic molecules, reducing toxicity. 4. ACLS, advanced cardiovascular life support. Follow ACLS guidelines for cardiac arrest management, avoiding vasopressin and high-dose adrenaline. Indications of regional anesthesia. RA. 1. Surgical anesthesia for extremities, abdomen, pelvis. RA provides effective pain relief for surgeries involving these areas, reducing the need for general anesthesia. 2. Obstetric analgesia, epidural. Spinal RA is widely used for pain management during childbirth, offering effective relief with minimal fetal exposure to anesthetics. 3. Postoperative pain relief. RA can provide prolonged pain relief after surgery, reducing the need for opioids and improving patient comfort. 4. Chronic pain management. Nerve blocks. RA can be used to manage chronic pain conditions by interrupting pain signals to the brain. 5. Diagnostic procedures. RA can be used for diagnostic procedures, such as nerve blocks, to help identify the source of pain and guide further treatment. Contraindications of regional anesthesia. Absolute contraindications. 1. Patient refusal. Patients have the right to refuse any medical treatment, including regional anesthesia. 2. Infection at site of injection. Injecting local anesthetic into an infected area can spread the infection and lead to serious complications. 3. Severe coagulopathy or anticoagulant therapy. Patients with bleeding disorders or taking anticoagulants are at high risk of hematoma formation. 4. Severe hypovolemia. For neuraxial blocks. Neuraxial blocks can cause vasodilation, worsening hypotension in patients with severe blood volume depletion. 5. Increased intracranial pressure. For spinal epidural, neuraxial blocks can potentially worsen intracranial pressure, leading to complications. Relative contraindications. 1. Sepsis. Regional anesthesia may be risky in septic patients due to potential hemodynamic instability and risk of infection spread. 2. Neurological disorders. Certain neurological conditions may be exacerbated by regional anesthesia or make it difficult to assess neurological function post-procedure. 3. Spine deformities. Anatomical abnormalities can make it challenging to perform regional anesthesia safely and effectively. 4. Severe cardiac disease, especially for high neuraxial blocks. Neuraxial blocks can cause significant hemodynamic changes, which may be poorly tolerated in patients with severe cardiac disease. Advantages of regional anesthesia. 1. Patient remains conscious. Patients can stay awake and alert during the procedure, reducing the risks associated with general anesthesia. 2. Avoids airway manipulation. Regional anesthesia eliminates the need for airway management, making it a valuable option for patients with difficult airways. 3. Better postoperative analgesia. Regional anesthesia provides effective pain relief after surgery, reducing the need for opioids and improving patient comfort. 4. Decreased blood loss. Sympathetic block. Sympathetic blockade can lead to vasodilation, reducing blood pressure and potentially decreasing blood loss during surgery. 5. Reduced risk of PONV, postoperative nausea and vomiting. Regional anesthesia can lower the incidence of PONV, improving patient recovery and satisfaction. 6. Early mobilization and recovery. Effective pain control and reduced opioid use enable patients to mobilize earlier, promoting faster recovery and reducing complications. Disadvantages of regional anesthesia. 1. Limited to specific surgical sites. Regional anesthesia is not suitable for all types of surgeries, limiting its applicability. 2. Requires skill and anatomical knowledge. Performing regional anesthesia requires expertise and a thorough understanding of anatomy. 3. Risk of failed or incomplete block. There is a risk that the block may not be effective or may wear off during the procedure. 4. Complications. Nerve damage from needle trauma or local anesthetic toxicity. Last, local anesthetic toxicity, from accidental intravascular injection. Hypotension from sympathetic blockade, potentially leading to hemodynamic instability. 5. Patient anxiety if awake. Some patients may experience anxiety or discomfort during the procedure if they are awake, require additional sedation or support. Special applications of regional anesthesia. 1. Obstetrics. Epidural for labor. Provides effective pain relief during childbirth, allowing mothers to stay awake and participate in the delivery process. Spinal for C-section. Offers rapid onset of anesthesia for cesarean sections, ensuring a pain-free experience for the mother. 2. Orthopedics. Peripheral nerve blocks for joint replacement. Enables effective pain management for orthopedic surgeries, reducing opioid requirements and promoting faster recovery. 3. Thoracic surgery. Thoracic epidural or paravertebral block. Provides excellent pain relief for thoracic procedures, reducing respiratory complications and improving patient outcomes. 4. Chronic pain. Nerve blocks. Interrupts pain signals to the brain, providing relief for chronic pain conditions. Epidural steroids. Delivers anti-inflammatory medication directly to the affected area, reducing inflammation and pain. Post-anesthesia care for regional anesthesia. 1. Monitor block regression, motor, sensory, autonomic. Tracking the resolution of the block ensures that the patient regains normal function and sensation. 2. Observe for hypotension. Monitoring blood pressure is crucial, as sympathetic blockade can cause vasodilation and hypotension. 3. Observe for urinary retention. Regional anesthesia can affect bladder function, leading to urinary retention, which may require catheterization. 4. Observe for PDPH, post-dural puncture headache. Patients who undergo neuraxial anesthesia may experience headaches due to dural puncture, requiring appropriate management. 5. Pain management continuation. Catheter techniques. Continuing regional anesthesia through catheters allows for prolonged pain relief and improved patient postoperatively. Comparison of general anesthesia (GA) and regional anesthesia. RA. Consciousness. 1. General anesthesia (GA) results in loss of consciousness, meaning patients are unaware of their surroundings during the procedure. 2. Regional anesthesia (RA), patients remain awake, although they may be sedated, allowing them to be aware and responsive during the procedure. Airway management. 1. General anesthesia (GA) requires airway control through intubation, mask ventilation, or laryngeal mask airway (LMA) to ensure adequate oxygenation and ventilation. 2. Regional anesthesia (RA) usually does not require airway intervention, as patients maintain control of their own airway. Analgesia. 1. General anesthesia (GA) provides pain relief during surgery but may require additional opioids for postoperative pain management. 2. Regional anesthesia (RA) offers excellent analgesia both during and after surgery, reducing the need for systemic opioids. Muscle relaxation. 1. General anesthesia (GA) achieved using muscle relaxant, allowing for optimal surgical conditions. 2. Regional anesthesia (RA) limited to the blocked region, providing muscle relaxation only in the area affected by the anesthetic. Physiological effects. 1. General anesthesia (GA) can have more systemic effects, including cardiovascular and respiratory depression, due to the anesthetic agents. 2. Regional anesthesia (RA) has more localized effects, resulting in less systemic involvement and potentially fewer complications. Postoperative recovery. 1. General anesthesia (GA) recovery can be slower, with a higher risk of postoperative nausea and vomiting (PONV). 2. Regional anesthesia (RA) typically allows for faster recovery and a lower incidence of PONV. Indications. 1. General anesthesia (GA) suitable for major surgeries that require unconsciousness and muscle relaxation. 2. Regional anesthesia (RA) ideal for surgeries involving the limbs, lower abdomen, and obstetrics, where regional blocks can provide effective pain relief. Contraindications. 1. General anesthesia (GA) severe cardiopulmonary instability may be a contraindication. 2. Regional anesthesia (RA) contraindications include patient refusal, coagulopathy, and infection at the site of injection. Complications. 1. General anesthesia (GA) potential complications include awareness, aspiration, malignant hyperthermia (MH), and postoperative nausea and vomiting (PONV). 2. Regional anesthesia (RA) possible complications include hypotension, post-oral puncture headache (PDPH), local anesthetic systemic toxicity (LAST), and nerve injury. Advanced regional anesthesia techniques. 1. Ultrasound-guided regional anesthesia. 1. Real-time visualization of nerves and needle, allows for precise placement of local anesthetic, improving block success and reducing complications. 2. Increases success, reduces complications. Ultrasound guidance enhances the safety and efficacy of regional anesthesia. 3. Especially used in brachial plexus, femoral, sciatic, TAP blocks. These blocks benefit from the precision and safety provided by ultrasound guidance. 2. Continuous nerve block catheter techniques. 1. Catheter left near nerve plexus for continuous infusion, provides prolonged pain relief by delivering local anesthetic continuously. 2. Excellent for postoperative pain control. Continuous nerve blocks are particularly useful in managing postoperative pain, reducing opioid requirements. 3. Example: epidural analgesia in labor. Continuous epidural infusion is a popular choice for pain management during childbirth. 3. Combined spinal epidural (CSE). 1. Spinal for rapid onset, epidural for prolonged analgesia, combines the benefits of both techniques, offering quick pain relief and extended analgesia. 2. Useful in obstetrics and major orthopedic surgery. CSE is particularly beneficial in these areas, where effective pain management is crucial. 4. Peripheral nerve field blocks. 1. TAP transversus abdominis plane block leading to abdominal wall analgesia, provides effective pain relief for abdominal surgeries by blocking nerves in the abdominal wall. 2. Rectus sheath block leading to umbilical hernia repair, useful for procedures involving the umbilical region, offering targeted pain relief. 3. Intercostal paravertebral block leading to thoracic surgery analgesia. These blocks provide excellent pain relief for thoracic procedures, reducing respiratory complications. Physiological effects of neuraxial blocks. Spinal, epidural. Cardiovascular effects. 1. Sympathetic blockade leading to hypotension, bradycardia. Neuraxial blocks can cause vasodilation, leading to decreased blood pressure and potentially bradycardia. 2. More pronounced in spinal due to rapid onset. The rapid onset of spinal anesthesia can lead to a more significant drop in blood pressure compared to epidural anesthesia. Respiratory effects. 1. Minimal effect in healthy patients. Neuraxial blocks typically do not significantly impact respiratory function in healthy individuals. 2. High spinal leading to respiratory muscle paralysis. A high spinal block can affect the nerves controlling respiratory muscles, potentially leading to respiratory compromise. Neurological effects. 1. Numbness. Patients may experience numbness or loss of sensation in the blocked area. 2. Motor weakness. Neuraxial blocks can cause temporary muscle weakness, affecting mobility. 3. Possible urinary retention. Blockade of sacral nerves can lead to urinary retention, requiring catheterization in some cases. Complications of regional anesthesia. 1. Spinal anesthesia complications. 1. Hypotension, bradycardia, due to sympathetic blockade, leading to vasodilation and decreased heart rate. 2. Total spinal, a complication where the block spreads too high, causing loss of consciousness, apnea, and cardiovascular collapse. 3. PDPH post-dural puncture headache, a headache that worsens when sitting and improves when lying down, caused by leakage of cerebrospinal fluid. 4. Infection. Rare but serious complications include meningitis and abscess formation. 5. Neurological injury, potential for nerve damage or persistent neurological deficits. 2. Epidural anesthesia complications. 1. Accidental dural puncture leading to PDPH. Unintentional puncture of the dura mater can lead to post-dural puncture headache. 2. Inadequate or patchy block. The block may not provide adequate pain relief or may be uneven. 3. Systemic toxicity. Accidental intravascular injection can lead to systemic toxicity of local anesthetics. 4. Epidural hematoma. A rare but serious complication where bleeding occurs in the epidural space, potentially compressing the spinal cord. 3. Peripheral nerve block complications. 1. Nerve trauma. Direct injury to nerves can occur during needle placement. 2. Vascular puncture, hematoma. Accidental puncture of blood vessels can lead to hematoma formation. 3. Local anesthetic systemic toxicity. Last, systemic absorption of local anesthetic can cause toxicity, affecting the central nervous system and cardiovascular system. 4. Infection. As with any invasive procedure, there is a risk of infection at the site of the block. Management of complications in regional anesthesia. 1. Management of hypotension. 1. IV fluids. Administering fluids helps to increase blood volume and blood pressure. 2. Vasopressors, ephedrine, phenylephrine. These medications help to constrict vessels and increase blood pressure. 2. Management of bradycardia. 1. Atropine IV. Atropine is used to increase heart rate by blocking the action of the vagus nerve. 3. Management of PDPH, post-dural puncture headache. 1. Best. Resting in bed can help alleviate headache symptoms. 2. Hydration. Staying hydrated is essential to help the body recover. 3. Caffeine. Caffeine can help relieve headache symptoms. 4. Epidural blood patch. Injecting a small amount of the patient's blood in the epidural space can help seal the dural puncture and relieve headache. 4. Management of high spinal. 1. Airway management. Ensuring a patent airway is crucial. 2. Oxygen. Providing supplemental oxygen helps to maintain adequate oxygenation. 3. Intubation. In severe cases, intubation may be necessary to secure the airway. 4. Cardiovascular support. Supportive measures, such as vasopressors, may be needed to maintain blood pressure. 5. Management of local anesthetic toxicity. 1. Airway support. Ensuring a patent airway is essential. 2. IV lipid emulsion, intralipid 20%. Lipid emulsion therapy helps to sequester local anesthetic molecules. 3. Benzodiazepines for seizures. Administering benzodiazepine can help control seizures. 4. ACLS, advanced cardiovascular life support. Following ACLS guidelines is crucial in managing cardiac arrest. 6. Management of epidural hematoma. 1. Urgent neurosurgical decompression. Prompt surgical intervention is necessary to relieve pressure on the spinal cord and prevent long-term damage. Safety protocols in regional anesthesia. 1. Pre-block checklist. 1. Informed consent, ensuring patients understand the risks and benefits of the procedure. 2. Fasting status, verifying the patient's fasting status to minimize risks. 3. Monitoring ready ECG, SPO, BP, having monitoring equipment ready to track vital signs. 4. Resuscitation equipment and drugs available, ensuring that emergency equipment and medications are readily available. 2. Aseptic technique. 1. Hand hygiene, performing hand hygiene to prevent infection. 2. Sterile gloves, gown, mask, wearing sterile attire to minimize the risk of contamination. 3. Skin preparation with antiseptic, preparing the skin antiseptic solution to reduce the risk of infection. 3. Test dose epidural. 1. Lidocaine with adrenaline. A test dose helps detect intravascular injection, which can cause systemic toxicity. 4. Monitoring. 1. Continuous vital signs monitoring, closely monitoring vital signs to quickly identify any potential issues. 2. Observe for signs of LAST, local anesthetic systemic toxicity, being vigilant for signs of LAST, such as neurological or cardiovascular symptoms, allows for prompt intervention. Indications for specific surgeries in regional anesthesia. 1. Spinal epidural anesthesia. 1. Lower limb surgeries, effective for procedures involving the legs, such as knee replacements. 2. Urologic surgeries, suitable for surgeries involving urinary tract. 3. Gynecological surgeries, useful for procedures involving the female reproductive system. 4. Obstetric surgeries, commonly used for pain management during childbirth and cesarean sections. 5. Lower abdominal surgeries, effective for procedures involving the lower abdomen. 2. Brachial plexus block. 1. Arm and shoulder surgeries, provides effective pain relief for procedures involving the upper limb. 3. Femoral sciatic block. 1. Knee replacement, provides excellent pain relief for knee surgery. 2. Leg surgeries, suitable for procedures involving the lower limb. 4. Caudal epidural. 1. Pediatric perineal rectal surgery, commonly used in pediatric patients for procedures involving the perineal or rectal area. 5. TAP paravertebral blocks. 1. Postoperative analgesia in abdominal thoracic surgery, provides effective pain relief after abdominal or thoracic procedures. Regional anesthesia in special populations. 1. Obstetrics. 1. Epidural. Gold standard for labor analgesia. Epidural anesthesia is widely considered the most effective method for pain relief during labor. 2. Spinal. Preferred for C-section. Spinal anesthesia is often preferred for cesarean sections due to its rapid onset and effectiveness. 2. Pediatrics. 1. Caudal anesthesia common. Caudal anesthesia is frequently used in pediatric patients for procedures involving the lower body. 2. Lower doses of local anesthetics required. Pediatric patients require smaller doses of local anesthetics due to their smaller size and developing physiology. 3. Elderly. 1. More sensitive to drugs. Older adults may be more sensitive to the effects of local anesthetics, requiring careful dosing. 2. Risk of hypotension higher. elderly patients are at a higher risk of experiencing hypotension due to decreased physiological reserve. 4. Cardiac patients. 1. RA reduces stress response. Regional anesthesia can reduce the stress response to surgery, which may be beneficial for cardiac patients. 2. Need to balance hypotension risk. Careful management is required to balance the benefits of regional anesthesia with the risk of hypotension in cardiac patients. Advantages of regional anesthesia over general anesthesia. 1. Safer for patients with difficult airway. Avoids airway manipulation. Regional anesthesia eliminates the need for airway management, reducing the risk of complications in patients with difficult airways. 2. Better postoperative analgesia. Effective pain relief. Regional anesthesia provides excellent pain relief after surgery, improving patient comfort and satisfaction. 3. Less systemic drug use, opioid sparing. Reduced opioid requirements. Regional anesthesia can reduce the need for systemic opioids, minimizing side effects and promoting faster recovery. 4. Reduced stress response and thromboembolic risk. Reduced stress response. Regional anesthesia can decrease the body's stress response to surgery, which may reduce the risk of complications. Lower thromboembolic risk. Regional anesthesia may reduce the risk of thromboembolic events by improving blood flow and reducing the risk of venous stasis. 5. Faster recovery and early mobilization. 1. Faster recovery. Regional anesthesia can promote faster recovery by reducing the need for systemic anesthetics and opioids. 2. Early mobilization. Effective pain relief enables patients to mobilize earlier, reducing the risk of complications and promoting faster recovery. Regional anesthesia quick notes for exam and OSCE. 1. Definition. 1. Drug-induced blockade of nerve conduction. Regional anesthesia involves blocking nerve conduction to produce loss of sensation in a specific region. 2. Order of block. 1. Autonomic. Pain, temperature, touch, pressure, motor. The order of blockade progression helps understand the sequence of sensory and motor block. 3. Drugs. 1. Amides, lidocaine, bupivacaine, ropivacaine, commonly used local anesthetics for regional anesthesia. 2. Esters, procaine, another class of local anesthetics, though less commonly used today. 4. Antidote for last. 1. IV lipid emulsion. IV lipid emulsion is used as an antidote for local anesthetic systemic toxicity. 5. Absolute contraindications. 1. Patient refusal. Respect for patient autonomy is crucial. 2. Infection at site. Performing regional anesthesia in an infected area can spread the infection. 3. Coagulopathy. Patients with bleeding disorders are at high risk of hematoma formation. 4. Severe hypovolemia. Neuraxial blocks can worsen hypotension in patients with severe blood volume depletion. 5. Raised ICP. Neuraxial blocks can potentially worsen intracranial pressure. 6. PDPH management. 1. Conservative management. Initial management includes bed rest, hydration, and analgesics. 2. Epidural blood patch. An effective treatment for PDPH, involving injecting a small amount of the patient's blood into the epidural space. 7. Spinal versus epidural. 1. Single shot versus catheter. Spinal anesthesia is typically a single injection, while epidural anesthesia involves placing a catheter for continuous infusion. 2. Subarachnoid versus epidural space. Spinal anesthesia is administered into the subarachnoid space, while epidural anesthesia is administered into the epidural space. 3. Rapid versus titratable. Spinal anesthesia has a rapid onset, while epidural anesthesia allows for titratable dosing. Thank you for watching. If you liked this content, don't forget to Like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.